At the outset, thank you very much, ma'am, for giving me this opportunity to present one of our interesting cases. And a very good afternoon to everyone. On behalf of the Department of Pediatric Nephrology, IKDRC ITS, I will be discussing about a rare cause of hemolytic uremic syndrome in an infant. An 11 months old female, firstborn of a non-consanguineous union to a gravida 1 mother. Her perinatal course and her early 11 months, growth and development wise and health wise, she was doing absolutely fine. She presented at 11 months with complaints of fever and cough cold for a duration of 5 days, for which she had consulted a local pediatrician. During these consultations, when he identified positive sepsis markers, he chose to admit the child and started her on IV ceftriaxone and other supportive management in form of IV fluids and antipyretics. Within first 48 hours of hospitalization with the pediatrician, the child developed new symptoms in the form of reduced urine output and progressive swelling, persistent vomiting, and reduced appetite. So blood tests were repeated and they showed derangement of renal function and worsening hemogram. So in view of altered RFT, ultrasound KUB was done, which revealed the presence of a hypoechoic lesion at upper pole of the right kidney with suspicion of infection versus infarct. Because of this involvement of the kidney, ambiguous presentation, the child was referred immediately to our side. So when we had a chance to examine the child, we identified that she was fairly well grown and well developed with the height and with her length and weight appropriate for normal. On vital parameters, her respiratory rate was slightly increased with acidotic breathing, and her blood pressure was on the higher side, 114/84, stage 2 hypertension for her height and age. On head to toe examination, facial puffiness and pedal edema were confirmed, and she definitely appeared pale. Systemic examination, nothing much positive turned up on the cardiovascular and per abdomen examination. On respiratory findings, she did have acidotic breathing. Other than that, the lung fields were within normal limits. And on CNS, she was drowsy and irritable on arousal, but grossly examined motor and sensory systems as well as cranial nerves did not reveal anything alarming. On lab evaluation, her hemogram confirmed the presence of microcytic hypochromic anemia with hemoglobin of 6.7 grams per deciliter. She had leukocytosis along with thrombocytopenia. Her platelet counts were 50,000. Kidney function tests showed elevated serum creatinine 4.83 milligrams per deciliter with metabolic acidosis. Liver function test, her bilirubin was on the higher side with some component of transaminitis. There was indirect hyperbilirubinemia. Her coagulation profile was normal. So because of the microcytic hypochromic anemia and thrombocytopenia picture, we had our hematologists take a detailed look at her peripheral smear. And there was hemolysis with 8 to 8.5% schistocytes present. Neutrophilic leukocytosis with moderately reduced platelets. Picture was confirmed on peripheral smear as well. And there were no abnormal cells reported. Her LDH was significantly high, 3,113 units per liter. Her uric acid was also elevated. And serum haptoglobin, which is considered to be the most sensitive marker of hemolysis, intravascular hemolysis, was significantly low. Reticulocytosis was also present, which confirmed that we were dealing with the picture of microangiopathic hemolytic anemia here. The test which stood out as a red flag here was the direct Coombs test, which was +3 positive. We would have been very happy if a urine routine microscopy could have been done at this point, but since the child was anuric at presentation, a urine RM could not be done. Further evaluation, her sepsis markers, CRP was high, but this was actually in the falling trend compared to what investigations were done by the private practitioner. And clinically also, she was afebrile and no active sepsis was suspected based on her clinical presentation as well. Her blood and urine cultures did not show any growth. Other infections which we usually would like to rule out in the setting of anemia, thrombocytopenia, and deranged kidney function, like dengue, malaria, and leptospira were worked up, and all these tests were found to be negative. Immune workup, complement levels were worked up, and our C3, our lab C3 lower cutoff is 90. According to that, her C3 level was borderline low. C4 was normal. ANA and dsDNA were done, both of which were negative. And since she had the upper respiratory infection presentation at the time of beginning of this illness, we did a chest X-ray also, which was absolutely normal. On her ultrasound KUB, her right kidney was 7.3 into 3.8 centimeters square with increased echo pattern. And the initial findings of infection infarct were again confirmed on our scan, a 20 into 35 millimeters and 20 into 15 millimeter hypoechoic lesion at upper and the lower pole respectively were identified. And since there was no internal vascularity picked up on Doppler, the possibility of infarct was upheld in favor of infection. Left kidney was also 6.4 into 2.6 centimeters square in size. So both kidneys were significantly bulky, more than 2 Z scores. Her renal Doppler was done, which did not show any evidence of renal artery stenosis or renal vein thrombosis. So to summarize thus far, 11 months old female child with acute kidney injury, microangiopathic hemolytic anemia, and thrombocytopenia. We were dealing with the case of thrombotic microangiopathy. And approaching this patient with thrombotic microangiopathy, I have illustrated this very wholesome algorithm, wherein the thrombotic microangiopathy, as we all know, it is a histopathological diagnosis, and the etiological 3 possibilities that should be thoroughly evaluated in case of TMA, thrombotic thrombocytopenic purpura, the HELLP syndrome, and hemolytic uremic syndrome have all been covered in this flowchart. So we will approach systematically. We are dealing with a child, so obviously the HELLP syndrome possibility is ruled out. Thrombotic thrombocytopenic purpura is a case wherein the deficiency of ADAMTS13 causes overactivity of the von Willebrand factor, and in order to confirm this group of disorders, the test that we do is ADAMTS13 activity. In our case, the child had an activity of 20%. Value less than 10% is significant and warrants workup further. But since the activity of 20% was recorded for our child, we were definitely not dealing with TTP. So narrowing down to hemolytic uremic syndrome, secondary causes of hemolytic uremic syndrome with coexisting diseases. So the first 3 most common infective causes which we encounter in our setting, that is malaria, dengue, and leptospira. We've already ruled them out. There was no history of any offending drugs. Clinically and lab parameter-wise, there was nothing to suggest malignancy in our case. There was an suspicion of infection, the urinary infection on the ultrasound scan, presence of hypoechoic upper and lower pole lesions on the right kidney. There was suspicion of developing renal abscess. Urine routine microscopy, unfortunately, could not be done since the child was already anuric at the time of presentation. And that is why this report, which I have mentioned here, is done down the line 5 days into the illness on antibiotics. So presence of some pus cells here with the background of AKI does not actually confirm any UTI. Also, the urine culture did not show us any growth. The next group of illness in case of hemolytic uremic syndrome is the respiratory infections. Streptococcus pneumoniae was one infection which was immediately to be ruled out for us because of the DCT positivity. The direct Coombs test positivity is a red flag. We need to work this child up for Streptococcus pneumoniae. However, on the chest X-ray as well as clinically, there were no signs of pneumonia. And the other 2 infections which can also lead to hemolytic uremic syndrome are H1N1 and influenza A. we did a PCR test for both these infections, which turned out to be negative. Then comes the classical STEC-HUS, and since the child did not have any diarrheal illness to prompt further detailed workup in this line, STEC-HUS was ruled out. The other category is the cobalamin C defect HUS, the vitamin B12 metabolism pathway defect. So the screening test to identify this group of HUS, which is also very important in our case since we are dealing with an infant, these disorders tend to present very early on in life. The two investigations which should be done in order to rule in or out this group of disorders is the serum homocysteine level and the urinary homocysteine and methylmalonic acid levels. So considering the availability of tests in our laboratory, we did a serum homocysteine level, which was on the low normal side. Serum homocysteine in case of methylmalonic aciduria and hyperhomocysteinuria is elevated, simultaneous low methionine levels in the serum and elevated methylmalonic acid in urine and homocysteine in urine will be the hallmark of cobalamin C defect related HUS. So we did not do the amino acid profile and the urinary analysis, but low normal range of homocysteine in our case led us to confidently rule out cobalamin C defect HUS. This left us with the alternate complement pathway dysregulation group. So we did a C3 and a C4 level. As also mentioned previously, the C3 level was borderline low in our case. C4 was normal. We did an anti-factor H antibody assay, although very unlikely to manifest at this age. The common age group is 5 to 12 years, but still we went ahead and did the assay and it was normal. Since all the other investigations which were feasible in our setup were normal, we ended up sending genetic analysis in our case, whole exome sequence as well as the MLPA, the multiplex ligation probe amplification test, both were sent. So with this workup, now again revising, the case summary stands at 11 months old female child who presented to us with a preceding upper respiratory tract infection, edema, and oligonuria, microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury triad led to the diagnosis of thrombotic microangiopathy. After the detailed evaluation and workup, as illustrated before, we narrowed down our diagnosis to hemolytic uremic syndrome. The presence of low C3 prompted us to think on the lines of alternate complement pathway dysregulation. And also, since the child had presented with history of fever, positive sepsis markers, elevated CRPs, upper respiratory tract infection at the onset, a concomitant infection-triggered hemolytic uremic syndrome was another possibility kept in mind. There were two odd points which stuck out at this point of time: a positive direct Coombs test and the right kidney infarct. While everything else was fitting well into the picture, a positive DCT with no streptococcal infection and the right kidney infarct with this setting of TMA could not be explained. So we decided to approach one after the other, focusing on the DCT positivity. I will not go into the details of the direct agglutination test algorithm. But to summarize this, the most common causes of a positive DCT test leading to autoimmune hemolytic anemia are obviously autoimmunity. In our case, we already had an ANA and a dsDNA report done, both of which were negative. We went ahead and did an ACLA anti-cardiolipid antibody as well as an antiphospholipid antibody assay, and both these tests were also negative, leading to the confirmation that we were not dealing with the upfront case of autoimmunity. Drugs like levofloxacin, quinine, DOPA group of drugs, procainamide, these group of drugs can lead to a positive DCT test, and in our case, there was no such history. infections, viral infections known to trigger a positive direct agglutination test. And the commonly encountered culprits are the Epstein-Barr virus, the adenovirus, the COVID-19 virus. We did run a test for COVID-19, which turned out to be negative. And one organism, which is very, very commonly associated with a positive DCT test, also associated with the cold agglutinin titers being positive, is the Mycoplasma pneumoniae. So because of this DCT positivity, we ran a Mycoplasma pneumoniae serological test for IgM, which turned out to be positive, suggesting a acute or recent onset infection. EBV and adenovirus PCRs or serologies were not done for our child because of financial constraints and unavailability in-house. And the fourth cause of DCT positivity is malignancy. However, based on our clinical and laboratory parameters, this was highly unlikely. So coming to Mycoplasma pneumoniae has been a very enigmatic organism. The identification of this organism as a bacteria, the positioning of it under the taxonomy of a bacteria has been finalized only over the last 50 years or so, initially because of its fastidious nature, because of the absence of the cell wall, the classical cell wall of the bacteria, and because it had several overlapping features with other atypical organisms like chlamydia. It's the structural parameters of the organism, as well as its etiopathogenesis and its pathophysiology could not be clearly demarcated. Also, diagnosing a mycoplasma infection based on the serological tests available 3 to 4 decades back was very, very difficult. However, since the recent availability of advanced tests, as well as availability of PCR-based tests for detection of these organisms, we have been able to get more and more idea about how mycoplasma presents and what are its clinical manifestations. So although the terminology pneumoniae clearly gives us an idea that it's a respiratory virus, and the main portal of entry is through the respiratory tract, wherein it binds through specific adhescent molecules with receptors present on the respiratory epithelium. There are certain mechanisms by which it eventually evades the respiratory barrier and gains entry into the capillaries, the pulmonary capillaries, and eventually through them into the blood circulation. Once it is into the circulation, a hematogenous spread to other organs in the body is very well known, which results in varied extrapulmonary manifestations. Now, there are different mechanisms which have been elucidated regarding the extrapulmonary involvement in case of mycoplasma pneumoniae. The direct injury is basically the virus-mediated injury. The virus has a very strong affinity for the respiratory epithelium, of course, then the endothelial lining, the fibroblasts, and because of its interaction with these cells, it leads to the release of various interleukins, cytokines, various endotoxins, and the injury which is caused thereby is considered to be by direct effect of the virus. And this direct type of injury can involve various systems apart from the pulmonary system. The cardiovascular system, the neurological system are the most commonly affected systems by direct injury because of mycoplasma pneumoniae infection. The indirect type has been explained by neoantigen expression, autoimmunity activation because of mycoplasma infection, and by molecular mimicry mechanisms, pretty much similar to what happens with streptococcal infections. So the streptococcal infection resulting in rheumatoid arthritis or rheumatic fever or glomerulonephritis, these indirect pathways have a similar underlying etiopathogenesis with mycoplasma and manifestations of the hematological and hemopoietic system, neurological manifestations, as well as involvement of the genitourinary tract. The third involvement is that of the vascular system. The vascular endothelial lining has several receptors on which Mycoplasma pneumoniae adheres and binds, and this eventually results in vascular occlusion, which causes manifestations predominantly involving the hematological and hemopoietic system in the form of disseminated intravascular coagulation, splenic infarct. Neurological manifestations by vascular occlusion may manifest as stroke, striatal necrosis, thalamic necrosis, leading to a variety of neurological symptoms. Respiratory system involvement because of pulmonary embolism is very well documented with Mycoplasma pneumoniae. And very interestingly, the renal artery embolism, renal vessels, vasculitis of the renal vessels is also been reported in association with Mycoplasma pneumoniae. So in our case, we definitely have, apart from the hematological TMA picture, we are dealing with some vascular component involving the renal vessels. Coming back to the case, this demonstrates the course of the child during the first 2 weeks of hospitalization. So at the time of presentation, the red line traces the hemoglobin of the child, the blue line traces the creatinine down the line, and the yellow line traces the platelet counts. The arrows are indicative of the sessions of plasma infusions that we did for the child. So immediately, acute peritoneal dialysis was started for the child because there were signs of fluid overload as well as solute overload at presentation, and this was continued for a duration of 5 days. After our initial workup confirmed hemolytic uremic syndrome with a very strong possibility of underlying alternate complement pathway dysregulation, which is one of the most important causes of HUS presenting in the infantile period. We chose to treat this child with plasma infusions, and since the second day of admission, plasma infusion sessions were started with 20 ml per kg of daily plasma infusion administered, along with ultrafiltration generated during acute peritoneal dialysis sessions enabled us to administer this volume of blood products. The child also needed 2 units of PCV transfusion at the time of presentation on day 1st and 2nd. Now, with this management, over the first week, hemoglobin stabilized. The creatinine showed a falling trend, came down from 4.3 to 2 milligrams per deciliter by the end of the first week, and the platelets showed a gradual but sustained rise, and a platelet count of more than 150,000 was achieved by the end of the first week. So with this picture, by the end of the first week, we'll also have a simultaneous look at what treatment we gave. Because of the suspected underlying UTI, the IV ceftriaxone, which was initially started by the private practitioner, was continued and administered for a duration of total 10 days till we confirmatively ruled out the presence of a UTI with the negative cultures. Mycoplasma pneumoniae positivity, which had turned up by this time, prompted us to start oral azithromycin, which was started on the 4th day of hospitalization and given for a total duration of 5 days. Now moving to the second week of hospitalization, when we decided to come down on our frequency of plasma infusions to alternate day, child simultaneously had neurological involvement in the form of abnormal involuntary movements of the upper limb, which after confirmation with the pediatric neurologist were identified to be dyskinetic movements. These were accompanied with orofacial lip smacking and chewing movements. These involuntary movements prompted further neurological assessment in the form of MRI brain and CSF. We were, however, very reluctant to act on these suggestions from the pediatric neurologist, since the child had not shown a very good recovery of her renal functions. The creatinine was still more than 2 milligrams per deciliter. And CSF test with platelets just coming above 1 lakh, we were very reluctant. So we just went ahead with supportive management. Clonazepam was administered to the child as per the advice by neurology team. And because she was having persistent involuntary movements and was sleepless throughout the night, they also recommended melatonin, which was administered for a duration of 1 week. Down the line, within 3 to 4 days of this treatment with clonazepam and melatonin, she showed significant improvement. And by the end of the second week, the neurological picture was totally recovered. And this led us to keep the MRI brain and the neuroimaging plan on hold till further another creatinine was achieved. So by the end of the second week, we had a fairly satisfactory creatinine of 0.74 milligrams per deciliter. The platelets had gone up to more than 2.5 lakhs, and the hemoglobin was holding at 8.6 grams per deciliter with complete recovery of her neurological symptoms. So now, where does mycoplasma sit in picture with this neurological presentation? Common infections causing movement disorders. So while we are well aware about infections like the beta hemolytic streptococci, which is known to cause the Sydenham's chorea, tuberculosis because of the tubercles and space-occupying lesions might lead to such movement disorders depending upon the site of the brain that is involved. And these are also very well documented with Whipple's disease. Mycoplasma surprisingly came up as one of these organisms, and in literature, when we went back and saw the encephalitis manifestation of mycoplasma, which is a very well documented presentation with mycoplasma pneumonia infection, does present as dystonias, dyskinetic movements, and oxoclonus, myoclonus kind of involuntary movements are very well documented with mycoplasma. Now, this I quote from this I have borrowed from the article published very recently from the NIMHANS group in 2024 January. So with these two systems involved, now the third system, the neurological involvement, also fits very well into the mycoplasma pneumonia extrapulmonary spectrum. Coming back to the further management, the right kidney infarct and abscess, although we've already seen that mycoplasma can result in involvement of the renal vessels and various other vessels, leading to vascular occlusion, thrombosis, vasculitis kind of picture. Even cases with Kawasaki disease have a preceding mycoplasma infection. So now we know that this could possibly be explained by the preceding mycoplasma. Let us have a look at the CT renal angiography, which we were able to do in the third week once another creatinine was achieved. So the findings on ultrasound were reconfirmed. 25 into 37 millimeters non-enhancing hypodense lesion was noted at the upper pole, and a similar smaller sized lesion was noted at the lower pole of the right kidney. The dark gray part of the right kidney is the infarct. So this is the vascular phase. In this, we can clearly see that there is no vascularity in the upper pole as well as the lower pole. So this is an avascular lesion, which rules out the possibility of infective etiology or an abscess. And in this view, the beaded appearance, instead of a linear outline, there is an irregular beaded outline of both the right as well as the left renal vessels, which points very strongly towards a possibility of underlying vasculitis or inflammation of the vessel walls. So further course, to be continued, as I had previously mentioned, we plan to taper our plasma infusions. By the second week, we had come down to alternate day, and then subsequently down the line, we came down to twice weekly plasma infusions and then weekly. By the 6th week of illness, once we received the genetic report, just to remind that at the outset only, once we confirmed that nothing positive showed up on the complement, alternate complement pathway testing, as per the guidelines, we did send the whole exome sequence as well as the MLPA test. And by the 6th week of illness, these reports were with us. No genetic variant in accordance with the phenotype of HUS was detected on the whole exome sequence, and no large deletions or duplications were detected even on the MLPA testing. So the weekly sessions of plasma infusions were discontinued now. And the child was kept under very stringent monthly follow-up. Her hypertension, she was hypertensive. She required 3 antihypertensive medications in order to keep her blood pressures under control. So we definitely needed to keep a tab on that. And because of the interim neurological presentation, we were concerned about her further course development wise and her how she progressively achieved her milestones appropriate for age. All that has so far been good. Her HUS lab parameters were also followed up monthly, and no activity showed up on these monthly follow-ups. So at 9 months after the onset of this illness, on her last follow, which was recent, just 2 days back, the child is doing fairly well. Her antihypertensive medication requirement has gone down significantly. Presently, she's only on single drug, and her blood pressures are fairly controlled. Her creatinine was 0.38 milligrams per deciliter, hemoglobin 10.6 grams per deciliter, and platelet counts of 480,000. Her DCT has now become negative. C3 is normal, 128 milligrams per deciliter. Urine routine microscopy, there's no proteinuria, no RBCs. And her ultrasound KUB has shown that the kidney size, the bulky kidneys have now gone back to their normal sizes. And the right kidney, the upper pole lesion is no longer detected on the ultrasound. And the 10 into 15 mm hypoechoic lower pole lesion still is present. So this was a retrospective approach. We treated the child very aggressively. When the child came to us, definitely complement pathway was involved because there was low C3 and TMA, and we wanted to act very fast and aggressive, and we started the plasma infusions. But down the line, we identified that there was no underlying alternate complement pathway involvement. So we went back and did a thorough literature review. The 2 odd points that stood out led us to conclude that mycoplasma pneumonia was the causative agent, and all the pathophysiology can be explained by this infection. When we looked at the cases of hemolytic uremic syndrome associated with mycoplasma pneumonia, we came across these 4 case reports. The first one, reported in Pediatric Nephrology in 2013 by Gordon et al., was a case very, very similar to ours, a 1-year-old male child with a positive serology of mycoplasma pneumonia IgM, presented with hematuria, proteinuria, and AKI. And there were no other extrapulmonary involvements for this boy, luckily. Treated with macrolide, no plasma infusions were given. They were bold enough to hold the plasma infusions, and there was a complete recovery, renal recovery for him. The other 2 cases, again, pediatric cases, 6 years old children who presented with positive serology with AKI and no other overt extrapulmonary involvement. Renal biopsy done for one of these children did reveal the presence of thrombotic microangiopathy. These 2 children were treated with plasma infusions in addition to the macrolides. And while one of them was lucky to recover, the other succumbed and progressed to ESKD. The 4th case is that of an adult female who also was treated on the lines of glomerulonephritis with TMA, confirmed on renal biopsy. A lot of details regarding the treatment of this female are not known to us, but a complete recovery has been reported. So hemolytic uremic syndrome complicating mycoplasma pneumonia infection. This is the first case tabulated before, a 1-year-old boy who was treated with only macrolide antibiotics. And this child presented with hemolytic, microangiopathic hemolytic anemia, slightly decreased platelet counts, and mild renal impairment is what they've written here. And they treated him only with macrolides. So in our case, atypical hemolytic uremic syndrome triggered by mycoplasma pneumonia was unlikely since adequate investigations of the complement system showed no underlying defect. This I am quoting from the article. So they have concluded that since the mycoplasma pneumoniae treatment with a macrolide led to complete recovery, the possibility of an underlying alternate complement pathway dysregulation being triggered by this mycoplasma infection was not likely. And they, however, go ahead and give a word of caution that although no abnormality could be detected, the role of complement dysregulation as a susceptibility factor for atypical HUS cannot be completely excluded. and further go on to say that it is quite justifiable to go ahead and treat with plasma infusions if at all there is a strong suspicion of underlying complement pathway dysregulation, or until and unless you can thoroughly rule that possibility out. Mycoplasma pneumonia infection associated with anti-factor H autoantibodies in atypical hemolytic uremic syndrome. This article associates the presence of anti-factor H autoantibodies with the mycoplasma pneumonia infection. As we have seen that there are indirect pathways which could be activated by mycoplasma pneumoniae. So mycoplasma is a known infection to trigger autoimmune responses. And this autoimmunity, as a part of this autoimmunity, antibodies against complement factor H may be produced, and which may trigger the entire anti-factor H autoantibody atypical HUS uremic syndrome pathway. In the adult literature, there are several case reports wherein antibodies against ADAMTS13 were identified in circulation post-mycoplasma pneumonia infection, and the thrombotic TTP, the thrombotic thrombocytopenic purpura presentation was further documented. So anti-ADAMTS13 positivity following a mycoplasma pneumonia infection, ultimately resulting in TTP, managed with plasma infusions and successfully recovered, has been documented in adult literature. So this is about the TMA part of mycoplasma pneumoniae. It could either be a triggering factor for the alternate complement pathway underlying dysregulation, or it could pick the production of autoantibodies because of its autoimmune provoking mechanisms, and thereby lead to TMA. Now we focus on the thromboembolic complications, that is a vascular underlying etiopathogenesis, which leads to endothelial injury, vasculitis, and vascular thrombosis, embolism like events. So a recently published case in the Clinical Respiratory Journal, this one is from, interestingly, from China, and they report a total of 49 cases wherein pulmonary vascular thromboembolism was the most common extrapulmonary involvement, which was noticed with the mycoplasma pneumonia infection in children. In 13 cases, multiple anatomic sites were reported to be involved. And interestingly, the other lab markers which were positive in these cases were C-reactive protein, lactate dehydrogenase, and ESRs. Lupus anticoagulant was positive for 74.3, or close to 75% of these cases, and anticardiolipin antibody was also positive for approximately 60% of these cases. So autoimmune component leading to increased thromboembolic tendency and causing vascular thromboembolism of the pulmonary bed was most commonly reported. Now, these cases have been reported post-COVID. So mycoplasma, number of cases of mycoplasma pneumoniae causing atypical pneumonia post-COVID and extrapulmonary complications subsequently have been on the rise. Thrombosis associated with mycoplasma pneumonia infection. This is another review article which was published again in 2021, wherein apart from the pulmonary bed, the pulmonary thromboembolic events, other vessels in the abdomen have also been found to be associated. Most common thrombus is found within the splenic vessels, but renal and splenic, a case report of renal and splenic vessel involvement has also been there. So with this, what exactly are we dealing with as far as HUS in the pediatric age group is concerned? What is new? So one very interesting thing which has been highlighted by this article by Professor Raina et al. Is that newer infections, viral infections like SARS-CoV-2 and HIV have served as a trigger for pediatric atypical HUS. Even some case reports of vaccines associated with triggering atypical HUS are there in literature. So the classic infections like the STEC, and the Shigella dysentery infection, E. coli infections, the H. influenzae, and the streptococcus pneumonia-like bacterial infections of the respiratory tract are not encountered that commonly because of improved hygiene, because of improved sanitation, and because of vaccination, obviously. And these newer agents, like COVID, and perhaps like mycoplasma, may have come to the forefront, and we do need to watch out for these newer viral agents, bacterial agents, as causative factors for atypical HUS presenting in the pediatric age group. So the novel therapeutic agents that we still, unfortunately, in our Indian setup are deprived of. The eculizumab, the wonder drug, which is now considered to be the standard of care of all alternate complement pathway dysregulation mediated HUS, is not still available to us. The newer generations, the longer acting ravulizumab is already available, but that is a far-fetched dream for us. Other drugs like avocapan, which has come up in a big way as far as AAV management is concerned in ANCA vasculitis. It has been a newer drug which has come in the recent guidelines. It acts on the C5a receptor level, and it is also several trials to study its role in hemolytic uremic syndrome are ongoing. A multitude of other such experimental drugs are under clinical trials, and targeted therapy is what we should be looking at now. Instead of going ahead with plasma infusions and plasmapheresis, which, although effective, has several complications and limitations. I would just quickly sum up with our experience. Our department has managed some 8 kids with hemolytic uremic syndrome who are under the age of 2 years. And there are 2 kids, interestingly, who have a DGKE mutation, although a variant of uncertain significance on the whole exome sequencing. They phenotypically, they fit into DGKE. Both of them have a biopsy-confirmed thrombotic microangiopathy. One of these kids presented as infantile nephrotic syndrome, infantile onset nephrotic syndrome, and was already started on cyclosporin when biopsy was done. And the other kid had the presentation of TMA, hemolytic uremic syndrome. And since this child who is on cyclosporin with a creatinine of 0.6 on the last follow-up is edema-free, although some amount of lingering proteinuria is there, we have continued giving CNIs for him. The other child who is a case of DGKE was managed with plasma infusions because the presentation was that of HUS. And this was discontinued after the genetic report. He's doing fairly okay with the preserved renal function, but some amount of proteinuria is lingering. There are also children, 2 children with CFH deletion. Both of these children have pathogenic CFH deletion reported on whole exome sequencing, and they are doing fairly well with plasma infusions being administered every 3 to 4 weeks. And one child, unfortunately, who expired during the course of therapy, he had a presentation of HUS at 18 months of age, and on genetic analysis, nothing confirmative showed up, but one of the genes with MMA, CHC, VUS was reported, and that is why we treated him with hydroxycobalamin. But unfortunately, none of these therapies did him any good, and we lost the child. There are also children who were not identified to have any genetic variant presented with classic HUS, and we treated them with plasma infusions along with acute peritoneal dialysis at the outset, and the further plasma infusions were discontinued after genetic analysis report was with us, and we confirmed that there was no underlying complement pathway disorder. These children are all doing fairly well with normal creatinine, and some amount of proteinuria has been reported with 2 of them, but one child is doing very well. Hypertension is one finding which continues to be present with all these children, and they require 1 or 2 antihypertensive medications for the same. So I would sum this up with a take-home message. Hemolytic uremic syndrome is an entity which needs to be approached very, very systematically and thoroughly. There is no magic mirror which is going to give us a straightforward answer. We need to go stepwise, approach one after the other, eliminate causes one after the other, and then narrow down our diagnosis and reach to our final diagnosis. Infants with hemolytic uremic syndrome are a specialized group, and their causes are very much different from what we encounter in older children. So we have to work them up in a great detail. There are rare causes, but a lot of these causes are treatable and they definitely should not be missed. The epidemiology of HUS in the modern times is changing considerably, and in line with these changing patterns of community infections, we need to keep our eyes and ears open and work up even the most benign looking odd points more thoroughly. Mycoplasma pneumoniae is a masquerader with varied manifestations. So there is no clear-cut way of following up these children, but we need to keep them up under our regular follow-ups. We need to be very, very careful. There could be a component of underlying alternate complement pathway dysregulation, and we have to be watchful about that. Underlying genetic defects are often unmasked by environmental triggers, and it is always wise to overtreat, at least at first. Final word is HUS treatment. It is very high time that we upgrade to targeted over plasma therapy. Thank you.
Thank you very much, Shahenaz. It was really a very interesting presentation and very fascinating, because this, the polar infarcts on the right kidney is something which is very rare, and it's made us all aware that it can happen. And also for emphasizing that in many patients, mycoplasma may be a second hit to underlying complement disorders, which I think is becoming more and more apparent as we are doing more and more genetic studies for HUS. So any comments from the other? I will reserve mine I'll have some questions. I'll ask them later. So any more queries or comments from other people in the audience? Dr. Preeti, Kiran, anybody do you have any comments? Okay, maybe I'll just ask. So would you consider doing a DMSA for your patient somewhere along the way to see?
We have actually, I forgot to put up that slide. We have actually done a DMSA scan for this child, and it shows reduced tracer uptake on the right side with a lesion on the lower pole, which is in line with the ultrasound, the recent most ultrasound report. And there is a reduction in the tracer uptake with a function of around 36% as compared to the left kidney, which has good tracer uptake and is well functioning unit.
Okay, thank you. I have one more question. How old are the two infants, the DGKs, which you have?
So one child is around 2 years old now, and the other one is close to 2.5, 3 years now.
So their GFRs are good, is it?
Yes, ma'am. Their creatinine is holding, but they are proteinuria. They do have hypertension, and the creatinine is around 0.5, 0.6. I have not had access to their height, the recent most height though, because I have picked up all this data from our hospital database. So I will not be able to tell you their GFRs exactly, but they are doing okay.
Yeah, because no, it's interesting that you have put out all your data of the infants. That's a lot of effort. Because the regular DGKs, they do progress to end stage very rapidly by 1.5 years or so. When they're discovered, they're classically, as you mentioned, they're discovered with proteinuria, and they often don't last beyond about 48 months.
So the child who presented as infantile onset nephrotic syndrome, he definitely has proteinuria. And in between, when we had discontinued cyclosporin for him because he presented with some diarrhea-related AKI, he had like a full-blown nephrotic range proteinuria, became edematous, and like proteinuria was very, very marked for him. And then subsequently, because cyclosporin at least helped him to stay edema-free and kept proteinuria like sub +2, +3 range, we reinitiated the same for him.
Right.
His
Okay.
creatinine is
Thank you
around
very much.
0.6, which is for his weight of around 11 to 12 kgs. He's a smallish child, so it's not what we would desire. So obviously the GFR is
Yeah.
also borderline compromised for him, but yeah, he's doing okay for now.
Right.
Just
I would
one.
believe the VUS.
Can I ask one?
Both have been reported as VUS now. Yes, sir.
You had done APLA workup for this child who had.
Yes, sir. We had done a antiphospholipid as well as anticardiolipid and lupus anticoagulant also, and they were all negative.
Okay. And biopsy was not done in this child, no?
No, sir.
Okay. Fine. Thank you. Nice presentation and nice case.
Thank you, sir.
So if there are no other questions or comments, I think we'll end the session. Thank you very much once again, Shahenaz.
Thank you,
It was
ma'am.
an excellent presentation and we really enjoyed it. Thank you.
Are you
Thank
giving
you, ma'am.
aspirin for this child? Are you planning to keep on aspirin or any antiplatelet?
So that is one part which is debatable in our case because we have not put our child on any anticoagulant. The cases who had pulmonary thromboembolism were put on antiplatelets as well as this anticoagulant therapy at the outset. But what I have in my defense is we treated very aggressively initially with plasma infusions. So possibly whatever the prothrombotic and the antithrombotic imbalance that results during that phase may have helped us. We have not put this child on any antiplatelet therapy at all. Without any anticoagulation or antiplatelet, this child has shown improvement. The upper pole infarct has resolved entirely.
Okay.
So once you treat the mycoplasma infection, Dr. Anshuman here. Am I audible?
Yeah, you're audible, Anshuman. Go ahead.
Yeah. Once you treat the mycoplasma infection, and I think the autoimmunity goes away, and there is no
The
other
DCT
risk.
the DCT in the last visit is negative, so there is no autoimmunity evidence of any autoimmunity as of now. Please go ahead,
Correct.
sir.
So there is no risk factor as such, apart from that infection, for this child to develop a recurrent infarct or some other infarct in other places, because the vasculitis was due to that particular infection episode. And as such, that child doesn't have any other risk factors for the continuing vasculitis. Like he doesn't have the classical small vessel or large vessel vasculitis kind of thing. Like similar to the meningococcus associated vasculitis, this child probably developed vasculitis because of the mycoplasma infection. But the only thing that worries is that beaded appearance in the both the renal arteries that is been shown in the CT angio. So I don't know whether that was a congenital thing that is present or that was due to the vasculitis. That is also another thing that to be kept in mind. Probably it was a congenital abnormality itself.
It looks very suspicious of a FMD kind of a picture.
Correct.
Just like a book picture of fibromuscular dysplasia that they show that beaded appearance. I've only seen it in a book.
Correct. But child doesn't have any other like no neurofibromatosis markers or anything like that. And had classical.
She is not behaving in lines with that. She's her antihypertensive requirement has come down. Her the infarct at the upper pole is resolved now. Without with the FMD sitting there, it should be progressive.
Yeah, sure. No, I just said the appearance was exactly like
I agree, totally
just
agree. I'm just giving a counter view.
Yeah. So once again, thank you.
Thank you, ma'am.
This sensible amount of discussion. Thank you very much. Thanks to you. Bye-bye.
Bye, ma'am.
Thank you.